In terms of documentation tips, there's a couple of key things to remember as a third-year medical student. First, you got to get everything co-signed. Since you don't have an MD or a DO behind your name yet, you have to have everything co-signed by somebody who on your team does. So that'll be your intern, your resident. All your pages have to be dated and signed. Again, this is for paper charts. Obviously, for EHRs, that's going to be somewhat different. The key thing here that you have to remember is that for your teaching hospitals, they get reimbursed on the work that your team does. And so the documentation is actually very critical. It's key to remember that even though other team members are going to be doing lots of documentation, your documentation also counts as well too. Remember, it gets co-signed, so it becomes part of the medical record. Also, in terms of handwritten charts, anything that's illegible is pretty much considered no documentation. So remember that. You got to be careful to make sure that everything is legible. And then a lot of the issues about that in case law that's come down recently. And so just be aware about what your institution's policies about documentation is. Same thing about approved abbreviations. And so, there have been issues where QD for daily has been misconstrued as QID because this little dot here, if you draw it vertically, can look like QAD. And so, for example, most institutions will actually ask you to write out once daily as opposed to QD. Basically, the joke is to CYA, never CYOA, basically to cover your butt, never create your own abbreviations. Now, another major activity you'll be doing includes formal presentations, and this happens on the post-call day. On the medicine side, it's going to be longer than on the surgical side. You'll be presenting this to the resident or the attending, whoever the senior person is on the team, usually during work rounds. The way the formal presentation should be organized is it should really tell a story about what's happening, what's going on, why did this patient present, what's his or her issues, your chief complaint, your standard stuff, HPI, physical exam, labs, and all this stuff, as in a typical story, sets the stage. And then the assessment plan is really where you draw your team in and where you get the climax and the denouement. The bullet presentations tend to be obviously a lot more brief. They're usually a minute or less, and they're usually 15 to 20 key facts as opposed to the 5 to 7 minute medicine presentation or the 2 to 3 minute surgery presentation. This is typically done when you are signing out or a new patient, for example, or when you are talking to a consultant. Maybe you need to get a infectious disease consult on your patient, so you got to give them a blurb about that over the phone. And so these tend to be very terse. The key thing here is that for third-year medical students, this is probably one of the tougher things to do because you're really trying to figure out what are the key things that the other team needs to know or so forth. And so you're trying to boil it down to the essential things. And so that takes practice, and over time you'll get a feel for what's really important and what's not as important and can be part of the bigger picture for other presentations. In terms of daily ward activities, there's a couple of things that you need to be aware of, and again, it's all detailed in First Aid for the Wards, but there's going to be daily procedures on the medicine side. It may be things like getting blood cultures, doing blood draws, getting ABGs, maybe even putting in lines, for example. On the surgical side, it'll be things like suturing, wound care, wound dressing changes, pulling out chest tubes or other drains, that type of stuff. There's a lot of patient/family communication, and this is actually where you will spend a lot of your time. All the members of the team, you'll probably spend the most time doing this. And in a way, it's great because you actually become a bridge in some way between the patient/family and with the rest of the team. You'll be asking for consults a lot. There will be the data collection either through your hospital information system or getting results from studies like radiology, or you ask for a nuclear study, that type of stuff. Obviously, there's a lot of learning that goes with each of the patients, and we'll talk a little bit more about studying. And then, not to be demeaning, but you're also basically a walking supply cart. I'll explain what that means. You're probably going to be, of all the members of the team, you're going to be the best equipped person on the team. You're going to have, if you're on the medicine side, you're going to have pens and, reflex hammer, ophthalmal scope, otoscope, et cetera, et cetera. On the surgical side, you'll have dressing changes, you'll have suture kits and whatnot. Believe it or not, this stuff becomes really handy because as your team is physically moving through the hospital, as they're going from patient room to patient room, if they have to stop and go to supply cart or go to a part of the hospital away to get something done, then it actually slows it down. If you happen to have some of these key essentials and provide that for the team, you're really helping to keep the team moving forward, and it's extremely efficient. I, as the attending, or I, as the resident, I generally know that on the team, it's usually the third-year med student that's the best equipped. So we always rely on you guys to help us out in those areas. All right, let's talk about some survival tips. Let's talk about efficient time management and organization. So there's a couple of things that you need to do regardless of what type of system you use. You've got to commit all tasks to a to-do list so you can organize organize it by location. You can also organize it by patients, but you've got to get it all to to-do list. You also have to think about what tasks need to be done first. So, for example, things like ordering consults or calling for consults, those things have to be done early because the consult team needs time to get over, take a look at the patient, recommendations or opinion. If you order consults in the afternoon, it's not going to get done till the next day for sure. And if it's happened to be a key issue, then that's tough, or you're going to really have to suck it up and beg or get the resident to intervene. Other things, checking labs, perhaps put it off a little bit because that can be done quickly. You also want to organize all your tasks by location if possible. So if you are getting all the x-ray results, again, if you're getting it from some computer pack station, you either do that or you'll be down with radiology, so you can consult with the radiology guys down there. You do it all at once for all your patients and perhaps for some of the other patients on the team that you may be helping to cover. One thing that you want to become an expert in is an information system expert. You need to know how to work the computer workstation, especially if it has CPOE for the computerized order entry. For the labs, how do you get the labs? How do you get that onto your cards or to your PDA or to your smartphone or whatever computer system that they have? Can you get this lab information outside the hospital? So, for example, quote unquote, can you kind of pre-round before you even get into the hospital? A lot of systems should allow you to do that through VPN dial-ups and secure accounts, that type of stuff. Kind of like as I mentioned earlier, you want to keep all those SCUD essentials on board because it allows you to be efficient. You don't want to run back and forth to the supply closet. And again, chances are your residents often run out of that stuff, and you can help them be efficient by keeping all the key stuff on board. Finally, always be early. Do not underestimate the power of being on time, generally how good that makes you look. And on top of that, no team wants to get off to a late start, especially on the surgical side, where there's really a culture of being on time and moving out early as on a schedule because you have to be in the OR and at the operating table at 8 a.m. sharp. And obviously, it doesn't look good if you're late and your team's halfway down the hall on the third room. Let's talk about organizational A's. There's all kinds of systems that are out there, and again, first aid for the wards goes through the pros and cons. You just need to kind of experiment a little bit, get some advice from med students a year ahead of you, and find a system that works for you. As a medical student, I kind of did multiple systems before I settled on a note card system. I started off with a clipboard system with data sheets. Other co-med students use binders. You can 3-hole punch the forms and do it that way, or you can do note cards where you can do either a small 3x5-inch note cards that are in a little notebook, or you can just do a single ring on those. And then, of course, a lot of you guys are using smartphones, things like the iPhone, the Treos, and so forth. Obviously, there are some schools out there that mandate that you actually have a PDA/smartphone as part of your clinical clerkship. So that, of course, depends from institution to institution. And again, you just need to work through the systems and find out what works best for you. Or if you're mandated a certain methodology, then you need to understand it completely. For example, if they're telling you to use PDAs or tablet PCs or whatnot, then you need to know, again, how to work the system to get the data, to transfer the data, manipulate the data, and have it ready for your presentations, and also for ordering other studies and so forth. Right, let's talk about evaluations. This is something that is really under-discussed, I think, at a lot of institutions, and a big mistake in the sense that students don't really know what goes on with evaluations and how they get graded. It's a lot different in the preclinical years where it's really easy to say, hey, you got 95% on that test or 85% on the test. So evaluations make up a huge part of the Dean's Letter. The majority Dean's Letter, where it's UCSF or Hopkins or University of Lowell or whatnot, if you look at the text, usually just 3 or 4 pages are dedicated to the preclinical year, maybe a bit about your background, and then the bulk of the letter, this could be another 5, 8, 10 pages, depends on the institution, is going to be centered around your clinical evaluations. So it's really important to know what the evaluation criteria is. It's going to be based on your clinical performance. Of course, there's always going to be a significant part of it is clinical performance, but what aspects of clinical performance, professionalism, professional interaction, professional patient interaction, clinical skills, reasoning ability, and also are there other objective measures like the shelf exam? Is it 5% of the grade, 10%, 20% of the grade? So you need to know the breakdown as best you can, whether it varies from hospital to hospital and clerkship to clerkship. It's also very important to know who is evaluating you. So the attending, of course, signs off on the evaluation, but he or she is often using written evaluations from the residents, the interns, and perhaps other staff, including the nurses, the ward clerk, who are often providing additional evaluations. So you've got to be aware of where input can come into your evaluation. It's very important to clarify what the expectations of the team is from these evaluators early on as possible. And it doesn't hurt to be blunt. It says, hey, I'm interested in learning as much as I can, but I do want to know, is there anything particular that typically you're looking for, that you're expecting a third-year medical student to be able to do, know, or et cetera, et cetera. And then after you clarify the expectations, usually a week or two into the rotation, you need to start getting for some feedback. It could be just casual, hey, is this what you guys are looking for? Or, hey, I'm a third way through this rotation. I just want to maybe sit down for 5 minutes, 10 minutes for a cup of coffee and just get some more feedback from you about how I'm doing and what else should I be thinking about. And often the team would be appreciative of you asking about that. They know that you're in a situation you're being evaluated, and they also know that how critical this is for your dean's letter and ergo for your residency application.